I hope they go home and realize that this has to be organized in a way that is doable for the least interested of their fellow nurses and doctors where they work, and to see that this has to be, nutrition has to be individualized to patients, because one size will not fit all, and patients are very different. In particular in the ICU, it's a very heterogeneous population of patients, and you can't have guidelines which makes them all alike, because that will not be successful. Energy needs, you can guess about them or you can measure them, and that you do by indirect calorimetry, and that's the gold standard to do, and there are shortcuts in this way, but they have proven to be less effective or sometimes even dangerous, because the mean values may come off reasonable, but the scatter is much larger and the outliers are at danger, and the outliers are very difficult, at least, to be identified by clinical means. The devices used for indirect calorimetry, they are usually connected to a mechanical ventilator, and patients on mechanical ventilations, then it becomes reasonably easy to do it. There are some obstacles, but these are minor, so it's easy to do, and with modern equipment it's also easy to do. It's not time consuming. The problem comes when patients are not on mechanical ventilation, and that is another issue, because to use masks or hoods or things like that are much more difficult, and in that situation you need a patient who can stay without extra oxygen, because that will be problematic. But for patients on mechanical ventilations, it's easy to do, and yeah, that's a cornerstone as well, to have a proper record over what is subscribed and what is given, and the different components of it as well, because otherwise you're totally out in the dark or out in the blue and don't know what you are giving. And the problem is, to some extent, that in the acute phase of critical illness, the energy expenditure is not identical to the energy needs, because you have a mobilization of endogenous substrates which cannot be suppressed, and if you give what you measure, you will be to some extent overfeeding, perhaps not dangerously, but if we come back to the shortcuts with formulas or whatever, then you may be much off too high and overfeed patients, which has been focused upon lately. You may have serious complications to that. Yeah, it's important that everybody cares about it, that this is a natural part of the round to discuss this. What type of energy expenditure do we have? What type of nutritional content should we give to patient? Is patient in acute phase? The level of insulin resistant may give you a clue to how much of the endogenous substrates are mobilized and cannot be suppressed, and therefore you may decide to give 70% of measured energy expenditure or 80% or something like that in the acute phase. Later on it's different, but in the acute phase people have become more aware of that you may do mistakes by overdoing nutrition.